should we start? It's 9:02. We're up to 40 participants, so we're getting there. Great, thanks, Margaret. Can you make the yeah, perfect. Okay, so today we are at Columbus, Ohio, and I'll start by next slide. I'll start by thanking our team. Members are here. Obviously, the DC&R editor is Dr. Galantiak, and she oversees all this, so we're very grateful for her support. Next slide, please. This is the brief disclaimer. Next slide. So a little bit about Columbus, Ohio, named, of course, after Christopher Columbus. It's the capital city of Ohio, and it's the biggest city in Ohio. One of the fun facts that I've found is that there's a statue of Arnold Schwarzenegger in Columbus somewhere. And I would really like to know from the host institution why and where. Next slide, please. So we're indebted to Professor Kalady, who reached out to our team and was a keen supporter of this initiative. Professor Kalady is the chief of colon rectal surgery at OSU, and so I would be very grateful if he sort of takes a couple of minutes to talk about the institution and introduces the panel today.
Great. Well, thank you, Dr. Bolshinsky. Really, really honored to be able to host this and have our faculty on this forum. A couple quick things. So Ohio State University is one of the largest universities in the United States, known for many, many things, of which not the least is the Big Ten football. And we seem to be a champion year over year. I'm not sure if it's Michigan people on the line, but they haven't beaten us in about 10 years. But then within the College of Medicine, it's huge. We are the Ohio State Wexner Medical Center, as well as the James Comprehensive Cancer Center and other different specialty hospitals, including Nationwide Children's. Within our division, we have 8 colorectal surgeons. We do the whole gambit of things. We have a fellowship as well, a large general surgery residency, which actually just been rated one of the top in the country. And we do everything: colorectal cancer, hereditary colorectal cancer program, very strong multidisciplinary IBD center, pelvic floor program. And one of the few programs with Dr. Gaisier doing transitional care, working with Nationwide Children's Hospital and transitioning over to adults. So we've got a great faculty. It's in a wonderful area. If you're ever in Columbus, we invite anybody to come visit anytime. In terms of the Schwarzenegger statue, I'm going to ask Dr. Harsman to maybe comment on that, who's also our residency coordinator for the general surgery program. Arnold's got some connection here, and there's a bodybuilding tournament here, I think, every year. But I'm going to ask Dr. Harsman to weigh in.
I don't know how it got started, and I have not. I've seen pictures of the statue, but I haven't seen it. But it's called the Arnold. It's a bodybuilding convention every year here in the spring, and they bring in all of the protein shake vendors and a bunch of bodybuilders, and they have a big competition. He's usually in town for that, so that's how that got started.
Safe to say, none of our colorectal surgeons have participated in that event.
Next slide, please.
So I'll introduce our panels, the people who will be presenting. So Dr. Sean Whalen is our current colorectal surgery fellow who has a few more days left with us. And Dr. Dom Bernikas, who just finished his general surgery program, is our incoming fellow. And Dom's been nice enough to, before starting, to participate in this as well. And our 2 faculty discussants are Dr. Harsman, you just heard from, and Dr. Hussein as well for discussion of those papers. Next slide for our panel. Dr. Mark Arnold, I'm not sure if he's going to be able to make it. He's one of our senior surgeons, been here for 30 years. Dr. Traugott as well. Dr. Emily Wong I saw on as a panelist. Dr. Gaisier, who I mentioned earlier, is also one of our panelists. Dr. Lisa Cunningham, another one of our faculty. Then we're really lucky to have Dr. Kristen Foley as well joining us. She's a professor of radiology, and she'll help comment on some of our radiology questions that we'll come up with today.
Next slide, please. So we'll start with the poll, and the poll for this month is what is the weakest link in the management of rectal cancer? So please tick what you think, and we'll discuss it in the end of our session. And whilst we're doing that, I'd like to thank both Dr. Foley and Dr. Kalady. I reached out to Dr. Kalady and asked about having a radiologist on because we haven't had one before, and I think it's fantastic having a bit of cross-pollination of different ideas, particularly given that rectal cancer is such a multidisciplinary approach in terms of our decision-making. Next slide, please. So we'll start with our first paper, which is the selection of patients with rectal cancer for preoperative chemoradiotherapy, at T category and nodal status, all that matters. And as Dr. Kalady already introduced the presenters, but I'd like to thank both Dominic and Alan Husman for participating in this.
Thank you, Dr. Bolshinsky. I'm glad to be here with everybody, and I appreciate the opportunity to present. So next slide, please. The current NCCN guidelines for treatment of rectal cancer recommend neoadjuvant chemoradiation for patients with stage 2 and stage 3 rectal cancers. This standard was established by several trials which demonstrated that the addition of neoadjuvant chemoradiation for patients with locally advanced rectal cancer decreased rates of local recurrence and increased disease-free survival. Since the publication of these landmark trials, rectal MRI has been increasingly adopted as a modality of choice for clinical staging of rectal cancer. Use of preoperative MRI not only improves the accuracy of clinical TNN stages, but can also provide additional measurements such as the tumor distance to the mesorectal fascia, in essence, predicting the likelihood of a clean circumferential resection margin after TME. More recent trials, namely the Mercury and the Occam studies from Europe, examine the use of MRI predicted circumferential margin to select patients for neoadjuvant chemoradiation, irrespective of their nodal status, and found comparable rates of local recurrence and disease-free survival to the current standard of care. It is notable that their approach avoided neoadjuvant chemoradiation in up to 40% of patients with locally advanced rectal cancers. In the context of these exciting results, the authors of the manuscript we are discussing tonight wanted to look at the reliability of using MRI for assessment of tumor distance to mesorectal fascia, T-stage, and lymph node status, and measured radiologist inter-rater agreement in a real-world setting. Next slide, please. This study was part of a broader initiative to introduce synoptic MRI reporting in the province of Ontario, Canada. All GI radiologists who read rectal MRIs as part of their practice were invited to participate. Participants were asked to interpret and report on 5 pre-selected pelvic MRIs showing biopsy-proven rectal cancer and to attend a webinar to review the results. Inter-rater agreement was measured for tumor distance to mesorectal fascia, T-stage, lymph node status, and extramural depth of invasion. 76 of the 111 GI radiologists in Ontario participated in the study, commendable response rate of 68%. Majority were men with 5 to 15 years in practice who reported 1 to 3 rectal MRIs per month. Next slide, please. In this study, the inter-rater agreement was highest for tumor distance to mesorectal fascia at 0.58, a value that's representative of moderate agreement in these types of studies. Inter-rater agreement for T-stage, lymph node status, and extramural depth of invasion only showed fair agreement with lower values. Of note, inter-rater agreement for tumor distance to mesorectal fascia did not change significantly when results were stratified by radiologist experience and volume. Next slide, please. The inter-rater agreement values reported in this manuscript are somewhat lower than the values published previously. This is presumably due to enrollment of a real-world cohort of radiologists with variable rectal MRI experience in the study, as opposed to having a select few expert radiologists read many MRIs in other studies. Nonetheless, the reliability of predicted circumferential resection margin in terms of inter-rater agreement is consistent across all published studies on the topic. Next slide. So in conclusion, the authors showed that MRI measured tumor distance to mesorectal fascia is more reliable than T-stage or lymph node status when assessed in a real-world setting. These results, taken together with the outcomes from the Mercury and Occam trials mentioned earlier, suggest that perhaps MRI predicted circumferential margin is more useful in clinical nodal status and properly select patients who will most benefit from neoadjuvant chemoradiation. And with that, I look forward to our discussion on this paper.
Thanks very much for that. If I can get Dr. Hasman to give us his clinical view on the usefulness of this paper.
Yeah, thank you. I think it's certainly of interest, and I think the things that stuck out to me are the response rate and the sort of what is the reward for the participants to review these 5 MRIs and turn it in. I think you think about it, basically education and competition are the only things I can see here. They were offered to participate in a webinar. To do that, they needed to turn these in advance. And I think it's a really impressive response. And I think a hopeful sign in terms of, what we can offer other people to get them to participate in projects around rectal cancer. The authors sort of describe these folks as non-experts, but they are all GI radiologists. So I think there's still a level of expertise there. Certainly in our institution, we have a handful of GI radiologists, none of whom have read hundreds of these MRIs for trials, but they've read dozens and dozens over time. So I do think there's still a level of expertise that's different than sending it to a small community hospital and having them get an MRI and read by the same person that's going to then read the mammogram and then going to read everything else. One thing that stuck out to me is, what are we asking an MRI to do? There was an economist at Harvard named Clay Christensen, who's best known for this disruptive innovation work, which you might have seen. He's had several books about that. But one of the things he talked about is, what is the job you're asking something to do? The job you're asking your carrot sticks to do and the job you're asking your Oreos to do are kind of two different jobs, even though they're both food. And I think we need to be careful about what we're asking the MRI to do. Are we asking the MRI and the radiologist to be reliable, which is what it is in this study, which we are, but or is it clinically meaningful? Is the most important thing that we can resect the tumor, or is the most important thing about the MRI describing the patient's biology, in which case sticking with the T stage and the nodal stage might be more important, or is it just overall prognosis? And if the distance to the circumferential margin doesn't predict the overall prognosis, then I think we still lose something. When you first meet the patient, you get the MRI, you get the CT scans. I think that T and N staging on our current MRI scheme tells us a lot about what's likely to happen to that patient over the next several years. So I think it's important that as we go through this, that we don't only pick something that is reliably read, but also something where we maintain a real clear view of what the clinical usefulness is. Thank you.
Thank you. Great point. We're fortunate to have one of the authors on the call, or maybe even 2 authors, but certainly Dr. Pooney is on, and it's fantastic having authors to come in. So thank you for that. Just a couple of questions, or a question to you. What do you think the salient points are for the paper in terms of your aims of writing it?
Hi, yeah, thank you first of all for inviting us and having our paper today. My name is Dr. Pooney. I'm not sure if Aaron Kennedy, our senior author, is here as well. I think there's a couple of points we wanted to highlight. At the time when this paper was written, there wasn't a lot of data looking. There had been a focus towards accuracy of MRI. However, we weren't sure how that would apply in our Canadian context, particularly where care here is not centralized. So we weren't having 1 or 2 expert radiologists who were evaluating our MRIs, and instead we had a broader set. We felt that this had implications for potentially consistency and reliability of care. The other point to this is that we also, at the time of this, had our own prospective phase 2 study, which is called the Quicksilver study, which was also looking at using MRI-based criteria to select patients for potentially avoiding neoadjuvant chemoradiotherapy if they have good prognosis stage 3 tumors. And so in preparation for that study, we were hoping to evaluate, for us at that time, these newer preoperative staging criteria for selection. I think what this highlights for us in terms of the data is a couple things. The first is that the reliability of MRI, particularly for preoperative planning, is important. I do agree with Dr. Harsman's excellent points about what are we trying to use MRI for, and I agree that perhaps for prognostic reasons, T and M staging is more important. I think it also gives us a bit of pause about using the MRIs for decision-making regarding nodal status and the consistency of that. And I think that's something that may be touched upon in some of the other papers. Thanks again.
Thank you for that. Now, a couple of questions to the panel, and also from the audience. If you can put questions into the chat bar, that would be fantastic, and then we can discuss. The first question I have is kind of in relation to the MRI protocol. Now, some centers use gel, other centers do not use gel, and we're talking about T stage here. So what is the practice in OSU, and is there a difference in T stage with sort of using gel compared to looking at lymph node involvement, for example?
I'm going to ask Dr. Foley to comment on that one.
Sure, happy to comment. That's a very good question that you ask. And in fact, at Ohio State, we are in active discussion and in fact, moving towards a protocol, including interrectal gel. Now, there is a lot of disagreement or lack of consensus in the radiology community about the value of gel or not. I think in my sort of anecdotal experience, I find the gel to be very helpful in showing us exactly where the mass is. And that's especially the case with smaller, more subtle lesions, where sometimes in the collapsed rectum, it can be quite difficult to know exactly where the tumor is. I've read, there is some question, are we moving the tumor closer to the mesorectal fascia by instilling the gel? The most recent thing that I read that looked into that specific question was that the non-tumor involved portions of the rectum do get distended towards the mesorectal fascia, but the tumor, which is not sort of inherently distensible, really doesn't move, and that it didn't change that measurement. But it certainly can make it easier to find the mass, but there really is wide-ranging, thinking and lack of clear consensus. And at Ohio State, we have not been using it, and are moving towards implementing it. And then, if we decide it doesn't work for us or we don't feel like we're benefiting, then we'll take it back out. But it is a little bit of a moving target for us at this point.
Thank you. That's quite interesting. Another question about radiology, sort of technicalities. In a lot of studies, I read the difference in the Tesla number of the MRI, 1.5 versus 3. Inherently, I like big numbers, but apart from that, like, what is the actual point of knowing that stuff?
I would say there's not any really important part of knowing that. 3T is a stronger magnet, and theoretically we can get a slightly higher kind of signal to noise ratio. That said, 3T is more prone to artifact from metal, motion, gas, a variety of things. There are, and a lot of people who have metallic implants, for example, pacemakers or other metallic pacemakers are often conditional and can be scanned at 1.5T, but not at 3. So there are a lot of sort of clinical factors that may go into the decision-making about what magnetic strength we're using. In reality, I think in most patients, there's not a really perceivable difference in image quality in most cases between a 3T and a 1.5. I would not, and I don't think anybody does, I hope, try to do a rectal staging MRI on an open scanner, a 0.2 Tesla magnet or any of those things. If any of your patients ask about doing that, tell them no. We're not going to get good image quality on that kind of low field strength open MRI, but most sort of modern area 1.5 or 3.0 Tesla scanners will be able to provide us with a really high quality image.
Okay, thank you. Sorry for attacking you. The last question I have in terms of the radiological view on things is, in the study, it mentioned that most participants reported between 1 to 3 MRIs per month. and were 5 to 15 years into clinical practice. I mean, as a surgeon, and there are some centers where I get an MRI. In Australia, we work slightly differently, where the MRI seem to be better quality, or the report seems to be better, but I have no way of judging, you know, the competency of some of my colleagues. And so the question to you is, what is required to gain proficiency, and what do you think is required to maintain proficiency in reporting MRIs for rectal cancer?
That's a very good question. You know, I think fundamentally, all of us are going to get better the more we do something, but certainly having education about exactly what, you know, the surgeons need, what the standards are. I mean, there are, within the radiology world, there are various organizations that put out, you know, educational materials, that put out report templates, and we're working very hard at Ohio State to kind of move toward a standardized and utilization of a report template that's standardized and that is sort of put together by the Society of Abdominal Radiology and their special colorectal cancer disease-focused panel. And there are, you know, those kind of panels for other diseases as well. And, you know, across the profession, I think there's more movement toward standardization of reporting, education. In terms of volume of cases, I don't know that I can give you a good answer of sort of what, you know, how much is enough for, you know, to sort of be proficient. Doing tumor boards and getting feedback from surgeons, feedback from pathology, I think that always makes us better. And that is something we try to participate in and do as well.
Thank you. Now, Dr. Kalady, there's a question in the chat about potentially using EUS for early T1 and T2 tumors. Do you think it still has a role? Do you use it? Do you recommend it?
So I don't routinely use it. I think there is, when you're talking about early T1, T2, or a polyp versus T1, I think there's, in the low rectal tumors, there's still some utility in using that. I personally have not done an endorectal ultrasound in my clinic in years. That's just because of just the setup of how I practiced. But I think that does have some role to it. I want to get comments because I know some of my partners use it more, and you can see if other people in institutions have a comment. But I do want to say, just based on the MRI stuff we were talking about, you know, we're making decisions on how we should treat rectal cancer patients based on MRI. And there's two big parts to that. You have to have a quality of the actual image. And we see all the time stuff comes in, patients get images elsewhere, and then they come in, it's like, this is not really good quality. And we get that feedback from our radiologists. So having it done right is really, really important. And then also having radiologists to understand how to read these is really, really important. And as you see from the article, there's a lot of variability just in basic interpretation of films. And they kind of set that up so that some of them were tough ones, and that's why there's the most inter-reader variability. But for the radiologist to know, it's really important just to communicate. It's all about multidisciplinary teams, right? With your pathologist, with your radiologist. So at our tumor board, we, you know, give our clinical picture, say, I'm concerned about the margin here. I'm concerned about seminal vesicle involvement. What do you think? And they tell us what their thoughts are. So it's a give and take. It's not just reading a report. It's something we have to look at the images ourselves. We have to go over it with the experts. And then as Dr. Foley was saying, everything is really being templated. So those things have to be recorded in a templated model so we see them. But that template is based on what kind of we're asking for. And when you look at NAPRC, which I think you wanted to talk about a little later, there are educational modules both for surgeons and for radiologists, and there's templates that have to be filled out as part of that accreditation process. So I think just working together as a team and then having high quality imaging and high quality reads is really, really important. It's the kind of the whole foundation of treating rectal cancer, in my opinion.
I'll make a quick follow-up comment about MRI imaging, and that is that it's also critical that we do the right protocol for MRI rectal cancer staging. And that MRI is different than MRI, or I'm sorry, different than CT, where, you know, we have some variation in our protocols with CT, but CT we do more or less the same way in every patient. MRI is very much a sort of problem-solving tool in the abdomen, and we have to know what we are, you know, what is the clinical question, what is the area of the body that we're looking for. I'm going to protocol a pelvic MRI for ovarian cancer differently than a pelvic MRI for rectal cancer. And that's still going to be different from a pelvic MRI for perianal fistula in a patient with Crohn's. So the center or whoever is doing your scanning has to have dedicated specialized protocols for those very specific clinical scenarios.
Thank you. On that, actually, and that might have a segue into the next study. Is there a difference in reporting pelvic sidewall nodes versus mesorectal nodes, and also sort of the MRI protocol of evaluating them?
I don't think the MRI protocol is different for evaluation. I mean, we will describe where the nodes are and try to be pretty precise and specific about them and give specific sizes. But I don't know that we have, I mean, we talk about mesorectal nodes, and then I think we talk about nodes outside of the mesorectum. So that may be what you're getting at. And if they're in the inguinal region, I'm going to say that. If they're external iliac, I'm going to say that. Common iliac, I'm going to say that.
I guess from a blood flow point of view, we've got systemic versus sort of mesenteric drainage. That was my question, whether you have to time the imaging differently. That's all.
No.
Okay, thank you.
But if we could just ask Dr. Traugott to comment, she's probably the one who does the most endorectal ultrasound in our group, both for pelvic floor and maybe for rectal tumors as well. Dr. Traugott's nice enough to join us, taking time out of her time from her central surgical meeting. So she have her weigh in if you can.
Absolutely, please.
Sure. So I would say that I certainly wouldn't, I don't do endorectal ultrasound routinely for rectal cancer referrals that come to me. I will say that I have done them selectively in situations, particularly where I have an outside MRI that may not be as good a quality, or where the read from the outside radiologist with whom I'm less familiar is either fairly equivocal about what they see, or I have concerns that I see something different. Those are situations where I might do an ultrasound myself in the office, particularly where I'm concerned that it may be borderline T2, T3, and it may affect management. And so those would be the situations where I've done that in the past.
Thank you. So in the interest of time, I think we should push on with the next paper. That was great. So the next paper is titled "Who Should Get Lateral Pelvic Lymph Node Dissection After Neoadjuvant Chemoradiotherapy?" And the presenters who kindly volunteered are Dr. Whelan and Dr. Hussain. So Dr. Whelan, please take it away.
Thank you so much for having me here. Really happy to be able to present tonight. Next slide. So as local recurrence for rectal cancer has improved over the years with the adoption of TME and neoadjuvant chemoradiotherapy, lateral compartment disease is increasingly seen as an important mechanism of local recurrence. Lateral pelvic lymph node dissection has been done as a matter of course in the East without neoadjuvant chemoradiotherapy for many years, whereas in the West it's more neoadjuvant chemoradiotherapy and TME. But for patients with preoperative suspicion for lateral pelvic node disease, lateral pelvic lymph node dissection, in addition to neoadjuvant chemoradiotherapy, has been advocated for a mechanism of treatment for these patients. So the study aims, this paper, to determine the indications for lateral pelvic node dissection after neoadjuvant chemoradiotherapy in patients who are suspected of having lateral pelvic node involvement. Next slide. This was a retrospective study of patients undergoing TME and lateral pelvic node dissection over about 12 years at MD Anderson. Patients were included if they were suspected of having external or internal iliac nodes, as well as obturator nodes or obturator nodes on pre-op MRI. Patients with synchronous stage 4 disease were included if they were resected to curative intent. Patients were excluded if they had recurrent tumors on presentation or if they had stage 4 disease that was not completely resected, as well as those patients without the appropriate imaging. Patients were treated with long course neoadjuvant chemoradiotherapy, aside from one patient who had short course. About a third of them had induction chemotherapy as part of a TNT program. And then all patients had post-treatment imaging before surgery. The primary outcome was pathologic lateral pelvic node positivity, with secondary outcomes being rate of recurrence, pattern of recurrence, overall survival, disease-specific survival. Next slide. There were 64 patients included with a median follow-up of 39 months, and the median number of lymph nodes evaluated per patient was 3. Slightly over half of the patients had histologically proven lateral pelvic node metastasis. And of the patients who did, they had higher rates of lymphovascular invasion and larger post-chemoradiotherapy imaging lymph node size. Next slide. When they're stratified by size, 5 millimeters seemed to be an important cutoff. Patients who had a short axis post-neoadjuvant lymph node size of less than 5 millimeters, of those 13 patients, none had histologically proven lateral pelvic node metastasis. And of the patients whose nodes were 5 millimeters or more, about 2/3 of those had positive lateral pelvic lymph nodes. In the patients who had nodal sizes of 5 millimeters or greater, they had higher stage disease and also increased rates of lymphovascular invasion. Next slide. There were no lateral compartment recurrences in the entire study. There was only one local recurrence, which is an anastomotic recurrence in a lateral pelvic node negative patient. They did see higher rates of overall recurrence in the histologically positive group, as well as in the group, regardless of positivity, who had nodal sizes greater than or equal to 5 millimeters, although it didn't quite reach statistical significance. The 5-year overall survival, as well as the disease-specific survival, trended higher in the node negative patients. And of patients who had positive lateral pelvic node metastasis, about a quarter of them died of cancer within the study period, whereas none did in the other cohort. Next slide. So in conclusion, the authors suggest that neither neoadjuvant chemoradiotherapy or lateral pelvic node dissection alone is optimal for local control in patients with clinical evidence of lateral pelvic node metastasis. In this study, there was no lateral compartment recurrence with the combined treatment. And of the patients with nodal sizes of 5 millimeters or greater, almost 2/3 had histologically proven lymph node metastasis, whereas there were none in the group less than 5 millimeters. And the authors suggest that patients with rectal cancer with post-neoadjuvant chemoradiotherapy lymph node sizes of 5 millimeters or greater should be considered for TME and lateral pelvic node dissection. Next slide.
All right, well, thank you very much for that. Dr. Hussain, can we get you to share your thoughts?
All right. All right, first of all, thank you for the opportunity. We are really excited at Ohio State to host the SCARS Journal Club. Before I start, I have to let Matt know that I think I'm very confident I'm going to qualify for Arnold this year. So we will have participation from the Department of Colon Rectal Surgery in the Arnold competition, and I'll send you pictures. So anyways, so this is really, I mean, this is a great article. I congratulate the authors for a really very well-written article. And Sean too, I mean, she did a great job in corralling all, there's a lot going on in this article, and putting it in a matter of 5 slides is really, you did a great job there. So the issue that the authors attempt to address in this article is the fact, you know, they want to assess whether or not pelvic lymph node dissection should be performed. And this is a contemporary issue in colon rectal surgery. It's very similar to what we see in surgical oncology, where you know, there is a fairly decent disagreement between the East and West, namely Japan and the United States, where for pancreatic cancer or for gastric cancer, extended lymph node dissection is routine in Japan, and it's never been able to, we've never been able to show effectiveness conclusively, at least in the United States. Similarly, lateral pelvic lymph node dissection is something that's been in practice in Japan for a fairly decent amount of time, has never taken on in the United States. And this article, I think, is a good first attempt to really systematically evaluate this issue. It's, I think, overall, for me, the takeaway points were the fact that none of the patients with lymph nodes less than 5 millimeters had cancer in them. So what I think at this point is equally as important as the fact that most patients who had positive lymph nodes, their lymph node size were noted to be more than 5 millimeters. There are a couple of things that I may, want to bring to the attention of audience, and I'm not sure if authors are here, they may be able to comment on those as well. Some of the differences in survival noted between patients with and without positive lateral lymph nodes may be simply due to the fact that patients with positive lateral lymph nodes had a more advanced disease and more aggressive features, a higher incidence of lymphovascular invasion. And even more importantly, maybe these are the patients who did not respond to neoadjuvant chemoradiation. Therefore, the fact that they had poor survival is just because their biology was bad, the tumor biology was bad to begin with. So that's, I think that's one issue that was, that kind of, as I was reviewing the article, that stuck out to me. The other issue, I think, as the authors were very careful not to overstate their conclusions, and they were very cautious about that. However, they do mention that lateral pelvic lymph node dissection decreases the risk of local recurrence. And that mention is purely based on historical comparison. And even that, historical comparison with studies from Japan. Which are really not analogous to what we are doing here. So that's another point in this article which I would be a little cautious about, especially given the fact that there are really no true controls in this study. Overall, I enjoyed reading this article. I think this is a fantastic first attempt to really systematically evaluate this issue, which has long been an area of contention.
Thank you very much. I have a few questions for the panel, and there's a few questions in the chat as well. So I'm just going to try to incorporate it. So the first question I see is, does MRI timing matter after neoadjuvant chemoradiotherapy to evaluate lateral nodes? I'm going to extrapolate that a little bit more and ask, in terms of the original staging imaging that we always used to do, and now with the evolution of TNT and watch and wait, we have restaging. Which decisions are made on the original and which decisions are made on the restaging these days? Maybe Dr. Kalady, you can sort of say your view on this.
Sure. I think the timing does matter for sure. We know that the longer you wait, the more response you have. We know that there's lots of studies now that looked at 8 to even 12 weeks after chemoradiation is one of the better decision points for your imaging to say if you're going to have a complete response or not. A lot of the early data was all, they did randomized trials between 2 and 6 weeks, but then they said, well, since 6 was better, you could do it at 6. But over the last 10 years, probably people looked at waiting longer. So having, depends when you look at that MRI. So if you look at an MRI at 4 or 6 weeks, I don't think it's going to give you as much information. I tend, there's a couple questions you had in there, Bled, with the looking at your extent of resection. If you're going to I do all my surgical planning on the pre-treatment MRI, and that's based on data that says the tumor doesn't really implode on itself. The tumor more kind of scatters. So there's not this central where everything just kind of shrinks down. It's not shrinkage, it's more of a scatter of tumor. So even if you have what looks like gross margins, there's still about 50% of the time tumor that still has viable cells outside of the original margin of what you had grossly. And that was work done by Dana Hayden and Kalady a couple years ago. And I still kind of base my stuff on that. The other thing though is with watch and wait, you know, I think if you have a really good response and it's almost there, and now we're going into TNT and adding chemotherapy after the neoadjuvant chemoradiation, I think it's important to look and see. I guess I've changed on this a little bit. I used to always say you need to get that in between study. So when you're done your chemoradiation, before you're just going to decide to go on to chemo, you need to get that other MRI. And I think what people have found now is almost more than 90% of people have probably responded at least partially. And if they're not doing any harm, then they go right into the consolidation chemotherapy. So doing that MRI now, I think we're starting to get away from that a little bit and just doing it again at the completion of consolidation chemotherapy. So final decisions about watch and wait are going to happen after the complete restaging, after total neoadjuvant is done.
Thank you for that. There's another question on the chat that mentioned, you know, what did the positive lymph node patients die of? I'm going to extrapolate that as well. And so I assume that the lateral recurrences or positive lateral lymph nodes are a reflection of systemic disease. Do we all agree on that? Or if the tumors are very low, could it be a local manifestation of tumor sort of lymph node spread? And if it is those tumors that are very low with local manifestation of spread, would these patients be optimal for, say, watch and wait? Because ultimately, you know, you have a fixed tumor burden, which is amenable to radiation, and it's right there. And the primary cancer is probably within finger reach.
So I'm going to ask some of our other panelists to get involved, get Dr. Cunningham or Dr. Wong to make comments.
So I don't have a great answer to the question that you just asked necessarily, but I did want to point out a kind of young faculty perspective on the fact that lateral pelvic lymph node dissection is a relatively newer technique that many of us, especially in the US, are less familiar with. And so in considering doing that, especially with US versus Japanese patients, I remember actually being in a room at DDW listening to the Japanese presentation on this for the first time and looking at their beautiful pictures of these dissections and thinking I could never do that with my patients, just because of the body habitus that we're used to here versus in Japan. And so just kind of saying, hey, but I would certainly be willing to learn if we felt like it were the right thing to do. And I would also throw out that potentially robotic techniques might be nicely applicable. And that's something that we have available, you know, here fairly widely. So that's really the 2 cents. I'm sorry, I kind of divulged from your question, but I don't really have a great answer to the one that you asked. And I was just thinking about this other perspective.
That's totally fine. With that, actually, in terms of the Japanese, I think an interesting point is that I think their use of radiation is significantly different to the use of radiation in the Western sort of, you know, colorectal society, whether it's a cultural difference or whether it's because they are just built incredibly well for colorectal surgery. I don't know.
So I do think it makes it more challenging, and robotics is probably the way to go. Dr. Cunningham does a lot of robotics. I can have her comment in a second here, but I think a lot of people still, because we don't learn this technique, have urology do it or gynecology do it. I think it's something that we need to bring into our repertoire. I know there are some courses being held around by some of the more advanced people who do this a lot robotically. So, and I think as a society, we need to start kind of learning how to do this. Again, it's not a huge number of cases. It's only about 10% of all rectal cancers are probably doing it. So does everybody need to learn how to do this? Probably not, but I think every group that's going to be specializing in kind of a tertiary care center to take care of rectal cancer, at least one or two people need to know how to do this. So it's not that frequent. I see Dr. Masaris is commenting on that as well. But Dr. Can I maybe comment on your approach to robotics and how you think this may or may not work, particularly in obese patients?
Sure, thank you. I've actually done one of these as a combo with oncology, not gynecology, sorry, and watched our urologist do the dissection, and I thought it was incredibly slick, but definitely something that I really haven't done myself. But I do think that that would be something that would be interesting to learn, and I do think that having at least one or two people in an institution like ours doing it would be good. But they do that dissection all the time as part of their surgical cases. And, you know, I think the last time I've done one myself was when I was on a surgical oncology rotation as a resident. And so I don't know that it's in my skill set, you know, now, but I think the robot would play a huge role in that. And I think that we could partner with our urology oncologists to, you know, to learn how to do those cases and become experts at that. And I think it would be particularly useful in, you know, the larger patient population for visualization.
Thank you. Just a question on that. I remember when I was a resident comparing an axillary dissection for melanoma versus, say, for breast cancer, and the dissections are radically different. One was a lot more aggressive. Now, Dr. Masaris mentioned that in his center, the urologists, I think, do 6 dissections a week, whereas clearly colorectal surgeons do a lot less. We all know that. In the study, they described that they initially started sort of cherry picking, and then as the study evolved, they then converted their technique to do an en-bloc resection. So what do we think about that? Do we need to do a formal en-bloc resection for these? Is there a difference? And if we implement, or if we, you know, use colleagues from a different specialty, is it the same dissection that they're doing that we actually want?
I think it's hard to cherry pick, particularly if you're looking at even 7-8 millimeter nodes, which we're saying now are ones that we go after. It's hard to find that. And I think if you do have something there microscopically, there's a chance you're going to have other nodes that are positive as well. So doing the en bloc will get both, I think, that node and then any potential other nodes. So I think that's reasonable to do en bloc. I think this is a very controversial topic, and we don't have great data. These are small retrospective studies, but I think we have to have something in your algorithm to say, this is how we're going to do it. It may not be perfect, and I don't think we've got great guidelines necessarily, and they're kind of changing, but I think within each program, or if we as an entire, you know, society, you know, ask our society says this is how we do it, then that's what we come up with. But I think you have to think about, okay, you think someone's got pre-malignant or nodes on pre-treatment, they're going to go through chemoradiation, and it was a certain size or a certain morphology, still afterwards, then we're going to go and do the lymph node dissection. And I think everyone just has to kind of figure out what that is, what makes sense to you.
I think in the chat, Dr. Eisenstedt raised a very good question. What did these patients die of? And I think when you look at this article, I mean, it does not really go into the details of it, but it's clear that they did not have all of their failures were distant failures. They were not local failures. So the question remains whether or not doing the lateral lymph node dissection added anything to the prognosis of these patients. These patients have more aggressive disease, which is less responsive to, with poor biology, less responsive to a neoadjuvant therapy. These patients will do poorly regardless. So I think that these are all as Matt said, these questions are really not answered. And until we have a clear answer to those questions, it's going to be tough for us to adapt a relatively new technique, which is fairly alien to colorectal surgeons.
Okay, thanks everyone. There's a few more wonderful comments on the chat, but in the interest of time, we might move on to the next slide, which is the results of the poll. This is where Stephen Brentsetter comes into his own.
I know. That's my my starting moment. So the sharing of the poll has started. So for the question, which is the weakest link in the management of rectal cancer? We had a variety of options. We had a pretty strong showing for preoperative radiological staging. I think everybody is on topic tonight. And less response, but next most for lack of prehabilitation.
Fantastic. I might ask the panel to give their opinions on this. The top two being preoperative radiological staging. What do you think the future holds in improving that? And when we're done with that question, the second one is, what does the center do for prehabilitation, if anything?
Get Dr. Geiser involved here. Maybe make some comments, Ali.
Yeah, to address the second question first, for prehabilitation, I think sometimes in cancer, time is of the essence, both for the patient and for the clinician and what we have available to us. But we do try as much as we can to encourage. I don't think we don't necessarily have a formalized program where we put them through any kind of physical therapy training, or they definitely get seen by a nutritionist so we can optimize their nutrition as they're going through their therapy. But there's no formalized program like we have in some of our other disciplines where we do prehabilitation for them with either physical therapy or assigned testing that they go through. Certainly we do counsel them to, a strong patient going into surgery and chemo is, a strong patient coming out. But I think a lot of our patients also have, they may have poor access to some of these resources. And so then when they're coming to us from community centers, or they're coming to us from rural areas with our encatchment, it's difficult to get them to the necessary appointments, and then to add on additional appointments can be difficult. I think the bigger picture maybe in both these studies goes to rectal cancer. Should this be done at only high volume centers and not out in the community practice, as we've seen with radiologists, difference in imaging and reviewing and their access to care, and how can we really improve upon this disparate care? As far as, to me, I think that was really an overlying theme with both these studies. As to what imaging holds in the future, I wonder if Dr. Foley might be better able to answer that.
I don't know if I have a good answer for what will happen in the future. Certainly there are, many imaging modalities. MRI is sort of at this point our best tool for detailed assessment of local disease. And we're certainly not perfect at it. We're trying to get better, and there's plenty of room for improvement both in our own center and kind of in the community at large. There's just always so much information and data and content to try to keep abreast of. And then there's, systemic imaging with PET imaging and things like that. And I'm sure that people who are more involved in kind of molecular imaging than I am may have some interesting things in the pipeline. But unfortunately, that is not my area of expertise. So I don't have any super great insights into future molecular imaging type of things, but that may be in the pipeline.
No, I think one of the coolest things on the horizon is the use of artificial intelligence. Right now, actually, our GI people in us are one of the only centers in the world using artificial intelligence for colonoscopy and polyp detection, which is really fascinating. And I think imaging is going to be heading that way. And if you can use these kind of information to say, okay, pathology based on what you see, and then the artificial intelligence will come up with a much higher predictive value objectively rather than subjectively, not to put Dr. Foley out of a job. But I think that that's, maybe it's 10 years away, but I think things are heading in that direction. I think that's fascinating.
Thank you. It is very interesting. In fact, I'm going to plug the Journal Club because I think in November we have the University of Michigan, nothing to do with their football team, of course, but we'll be talking about artificial intelligence with them, or using that to for education. Thank you to all the people that participated. Thank you to the chat. I think we might there might be an attachment to Rodrigo Perez's protocol or something like that Dr. Debbie Keller will be posting in a second. But whilst we're doing that, perhaps we move on to the special guest segment. Of course, the special guest is Dr. Kalady. I was fortunate enough to be both his fellow and clinical associate a couple of years ago, and I think he's an excellent clinician to work for. Academically, of course, he is incredibly productive, particularly in hereditary colorectal cancer and cancer genetics, with over 300 publications and more than 7,000 citations, which I think is incredible. Most importantly, though, I think he's an excellent family man, and from a family perspective, I was just so jealous of how well his children were behaved when I saw them several times. I hope that as my kids grow up, they will be as well drilled as his. So now I'd like to focus this next segment on sort of the management of rectal cancer in a sort of in a bigger setting. And the first thing is about the NAPRC. And about its evolution and your involvement in the sort of accreditation for rectal cancer. Again,
thanks for the invite. And thanks for the nice comments about my kids. I think they put their best hat on every time they see you, maybe. That's not always the case. So, you know, I was lucky to be involved with the NAPRC in the beginning, probably about like 2013 or 14 even. Dr. Feza Ramsey and Dave Dietz and John Munson and Steve Wexner kind of got a group together, and they called it Ostrich at the time. And people have done this for years and years and years, but I think it just took some momentum to get people together. And Ostrich stands for Optimizing Surgical Treatment of Rectal Cancer. And then they opened it up, and they didn't want to be exclusive. They said anybody can come in and anybody could do this. And the goal was, how do we treat rectal cancer patients better? We look at, you know, a lot of people have done some stuff in the US. I think Rocco Riccardi, I'm not sure if he's on this discussion here, but he looked at some of the status, and like 40 to 50% of people in the United States were getting APRs for rectal cancer. Other things like our TME rate was poor, our margins were positive. And despite everyone kind of saying how great a job we were doing, when we looked at where we were in comparison to Europe, we were really beyond or behind the curve. And a lot of the difference was that in Europe, they had done standardization protocols, and they've done training programs, and they really kind of went out full bore on how do we make this better. And I think that was the impetus behind this. And then Ostrich took off, and they made it a multi-society thing. So the SSO got behind it, ASCRS got behind it, getting in American Radiology Association and Pathology, and kind of getting all the key players buying into it. And then the American College of Surgeons and the Commission on Cancer bought into it and took over. So the Ostrich kind of did their job, and they got it to a point where the American College of Surgeons now runs it. And the accreditation process is through the NAPRC, National Accreditation Program for Rectal Cancer, of which Steve Wexler is now the executive director. And it's a set of standards, and I think they're achieving what they set out to do, and that they wanted to improve outcomes for rectal cancer. And the metrics or the standards there's some process measures, and then there's kind of quality metrics along with that. And I think the biggest aspect of all of it is they really stress multidisciplinary care and the interpretation of an MRI and discussing the results and use of radiation oncology and medical oncology, who gets neoadjuvant therapy, now who gets consolidation therapy, pathology, making sure that we have good TME planes and the adequate lymph nodes are sampled. Part of it is that specimens are photographed so that you have quality metrics. So we see what our specimen afterwards, did we do a good job or not? And do we learn from that? Where was it hard, or where am I failing? So getting all those things together and getting those process measures and basically looking ourselves in the mirror to make sure we're doing a good job is really, really important. So that we've seen that come to fruition. I think there were a few centers that we were lucky enough in my former job to be one of the first centers accredited. And then it took a little bit of a screeching halt with COVID, but I think there's close to 30 centers that are now accredited now by the NAPRC. And from my understanding, there's a long list of others that are kind of in the docket to get accredited. Do you need to be accredited or not? You probably can take care of rectal cancer patients well without it, but I think it also puts your stamp of approval on it. And I know when we looked at it and we all thought we were doing a good job, but when you get these processes in place, it makes a big difference. We know when we did our multidisciplinary, our tumor board, and we started looking at some of these things before and after discussion, one study we did, 24% of our cases were actually changed in management. Some of that was a sequence of timing, some of it was for the workup, but even people who have been doing this for 20, 30 years had change in management when you brought it to a multidisciplinary board. So I think that's really important. I think the whole part of NAPRC is that it's multidisciplinary care, it's discussion, and kind of holding ourselves accountable. So sorry if I rambled there, but I think that's
no, that's really useful. I'll take you up on the tumor board comment that you've made. What do you think makes a successful tumor board team? And how do you build, the people that represent this? And another part to that question is I sometimes find that some of the discussions are like an itemized receipt where we just add more and more stuff. No one ever says, no, let's not do an extra test. We'll just do more. And how do you keep this cost effective?
Well, I think the kind of foundation of everything is you have to have people who buy in, who think it's important, and people who want to work together and realize that teamwork is really, really important. So like Dr. Foley's really engaged with the radiology group. We have pathologists who are very much engaged. We have medical oncologists, radiation oncologists, and the surgeons. So those are the 5 critical teams that are important to the tumor board. And I think this working together and communicating is the biggest thing. And realizing that, yes, we think this is important because it does take time. It's an hour once a week in our institution. It takes a lot of work to prepare it for our radiologists and pathologists in particular. But I think just getting that, kind of starts with why. Why are we doing it? We're doing it because we think it makes a difference, and we think we deliver better care to our patients when we have these multidisciplinary team discussions. In terms of this kind of laundry list, I think rectal cancer is pretty straightforward. It's the workup is a pelvic MRI and CT scan of chest and abdomen and a CEA, and that's it. That's all you really need. If there's something further, if they have metastatic disease, they might have to look at some different things, but you should keep it very focused on those tests. And I think the most efficient presentations are the surgeon says, this is a patient who had some bleeding. I did a scope. This is what the tumor looks like. Here's the imaging. The radiologist looks at it. Here's the pathology, confirmed diagnosis, CA workup. Based on this, it's a clinical stage 3, T3N1. We're going to do neoadjuvant chemoradiation. And you can zip through that pretty quickly. And I think having that too, and having these protocols and having kind of care paths becomes cost efficient because then you don't have people ordering all types of random tests like PET scans and everything else that may not be indicated.
Okay, thank you. Now, you lead a sort of a comprehensive colorectal cancer program. And we know over the last several years, the evolution of TMT and watch and wait sort of changes what we recommend. At what point does an experimental therapy become the standard of care within the tumor board environment?
So I think there's 2 parts to that. I mean, we're at a center with the James Cancer that does a lot of clinical trials. So we could put people on clinical trials and that's okay. It's all part of, how we treat patients. I think we also then have to go to guidelines. So the guidelines by NCCN, there's guidelines by ASCRS, whatever they are, we have to do what's standard of care. I'll think that guidelines are guidelines. Doesn't fit every person. Everybody's a little bit different. And somebody maybe should, based on the imaging, get TNT, but they can't tolerate a haircut, much less chemotherapy and radiation, and that's a local excision on somebody. So that guideline changes based on that individual patient. So you have to take the big context and picture. And then, so when does something become reality? I think a lot of it depends on clinical trials that are being run. I mean, OPRA trial and some others are looking at the effectiveness of TNT as opposed to kind of the standard neoadjuvant chemoradiation, then surgery, then consult, and then adjuvant. I think that data now is pretty strong, and guidelines. I don't recommend that everyone just kind of goes out on their own and starts doing things, but we have the luxury of having ASCRS and having NCCN help provide those guidelines for us. Do it.
Thank you. With the guidelines, I guess particularly for people in smaller centers or say in smaller countries like Australia, there are so many guidelines out there. Every acronym has their own set of guidelines times, on every continent. And what would you recommend in terms of the guidelines to follow? Because there are lots out there and they're all subtly different. So how do you filter that in a smaller center without, clinical trials being run?
I think whoever's delivering the care as a team has to come up with what guidelines they want to follow. So in Australia, you may say, we as our center want to follow, I'm not sure if Australia has their own guidelines or not, or you're going to follow whatever ASCRS says. I think you just have to pick one. You can't follow everybody's, and probably some of the different parts of the world, they practice differently. We see, what's the difference between the US and the West, or in Europe, they handle things very differently. So you have to see what works best for your local environment, both at kind of probably the local level, state level, and national level. But just pick something that's based, or you think, on reasonable data and what makes sense for you and your group, and then stay with that. I think as long as you stay within those guidelines and kind of have a reason for why you're doing it, you should be fairly safe and provide the best care for your patients.
Thank you. The last question I have is sort of stepping back a bit, but talking about sort of aggressive rectal cancer. We kind of have two extremes. We either aim to resect absolutely everything which would potentially have any cancer in it, or we use systemic therapy and don't do any surgery. Particularly with your expertise in both sort of the cancer genetics and also clinical experience, do you think that we have the right balance, or are we heading in future, are we heading more to aggressive surgery, or will we be heading more to sort of aggressive systemic therapy and less surgery? What do you think will end up?
Again, a great question. Still a lot of debate on all these things. I think when we have better biomarkers, we'll be able to probably do a little bit less surgery when we know who's going to respond to systemic therapy and who's going to respond to radiation better. We might be able to hang our hat on that a little bit and feel more comfortable not doing something. I do think there's a big push now. So like you're saying, so we don't radiate T1, T2s usually, but like Rodrigo's group in Brazil, they radiate those because they have a much higher percentage going into watch and wait. So you could say, maybe we should radiate every T1, T2, and they'll never need surgery. Whereas, you have the side effects of radiation, but then you don't have the side effects of surgery. That's where I think we're going, and I don't know what the answer to that is yet. I think when we have better biomarkers to figure out who's going to be a better responder or not, that will help guide some of these more systemic therapies and radiation therapies.
Thank you. Well, thanks for that. Thank you for your time. Do you have any sort of tips or any comments as a last sentence?
No, I mean, thanks so much for letting us do this. This is great. I think it's been a great discussion. Thank you for everybody who signed on and participated. I think the big part of this is just communication and teamwork. Rectal cancer is a team sport by far. And getting not only your own team as surgeons, but all the multidisciplinary teams together, and being open to discussion. You don't always have the right answer. Be willing to listen to what other people say, and it gives you, just be open to some different perspectives sometimes.
Thank you. So for everyone on the chat, there's in the chat attachment to the a technical note about lateral pelvic lymph nodes. Please download it if it's of interest. And from us, again, thank you very much for participating. Please tell people that these are recorded and available on the YouTube VCR channel. And we will see you next month at the same time, last Monday of the month, 7 p.m. Thanks, everyone.
Thank you.